A healthier you, making diabetes history on Guam.
Presented in partnership with Glt-2 Select Care and Paradise Fitness Center.
Coffee, everybody, and welcome back to The Link. As we have been doing all week long, we have been talking about diabetes as part of KUAM and AI Health's Healthier You campaign. We started off over the weekend interviewing Leon Guerrero about World Diabetes Day on Monday. We talked about the impact of diabetes on Guam with Frank Campillo from Glt-2 Select Care, as well as Dr. Dolores Lee. Yesterday, we talked about diabetes prevention with Rosea Calvo, Mike Scrow, Nurse Agnes White, and Boca Box Jess Rosario. Wednesday, we talked about diabetes and technology today. Today, though, we are talking about diabetes and the future. And we are so honored to have with us in the Zoom room, we have Dr. David Klonoff. He has known to be the founding father of diabetes technology, also coined the term diabetes technology. Also joining us in the Zoom room, we have Dr. Francisco Pascual. He is also an AI Health Advisor and member of the AI Health Clinical and Technical Oversight Board, specializing in optimizing care with diabetes technology. Good morning or good afternoon from your part of the world. Thank you so much for joining us.
Good day. We're both here to talk about diabetes, and Francisco and I have worked together on many projects. It's great, Francisco, to be able to see you. I'm in San Francisco and you're in Atlanta. So do you still feel that diabetes is an extremely important disease to treat?
Absolutely. Yeah, thanks for having us. And it's great to share with David and all of you. And happy to answer any questions and start the conversation and keep it going to try to make a change. And you know, it's a very high risk of diabetes in Guam, so hopefully we can help in whatever we can.
Well, gentlemen, doctors, we really appreciate your insight and your expertise on this subject. And Sabrina and I actually, it's an honor for us too, because we, I guess, unfortunately would be the right way to say it, are the children of at least one diabetic parent, both. So we're pretty intimately familiar with the treatment. And Dr. Klonoff, I'd like to start with you, as someone who has made a world-renowned name for himself in the treatment. A lot of people like myself that, these responsibilities were kind of thrust upon, kind of found, the treatment of constantly having to take, prick the finger for blood, or, like what I would do to my dad is, kind of like squeeze maybe a fatty part in his stomach for the injection of insulin. Those kind of treatments were maybe like a little crude, but I understand, like at the time, that's what technology supported and everything. Moving forward, how will technology and techniques be able to provide for the type of data and the type of medical feedback that you need, maybe without the types of readings that we've had to take?
Well, that's a really good question. I'm going to start off by saying that the very best treatments for diabetes involve having a healthy lifestyle. I am interested in technology, but what people eat and how much they exercise and whether they take their medicine is even more important than any technology in the world. But if a person is eating right and they're exercising regularly and taking their medicines, then the next step is there are technologies that can help. Many people with diabetes, as you said, will benefit from knowing what's their blood sugar at any given time so that they can make a decision how much extra to eat or not to eat, what kinds of foods to eat. And at one time, there was no way to even know what the blood sugar was. And then later, last century, people tested urine sugar, which was not very accurate. Then they transitioned now to blood glucose, which is the dominant way of testing glucose, at least the first 20 years of this century. But the topic of today is the future. And I think the future of diabetes, increasingly, blood glucose testing with pricking the finger, getting a drop of blood, is going to be replaced by continuous glucose monitoring. And this is a really amazing technology with a tiny wire that's like a hair that goes under the skin. It sits there and it's attached to a tiny ball that's outside the skin. And the wire measures glucose continuously every minute, every 5 minutes. And the ball sends a message to a smartphone, which sends the information to the cloud. And from the cloud, the information is sent back either to the smartphone or to a computer or to the doctor's office. So now instead of a person checking themselves maybe 3 or 4 times a day and having to prick themselves, which people often don't even want to do at all, they have an absolutely painless device. They don't even feel it sitting in the skin that's making a measurement a couple hundred times a day. And these continuous glucose monitors have an alarm. So if the blood sugar is getting too high or too low and the person can set their own limits, they get warned. So it's much easier now to know which foods affect the glucose, which activities, and whether a person is in danger. So I think the idea of checking the glucose continuously is a very good idea. There's also new ways of delivering insulin. I'm interested in those. I know Francisco is interested in those. I'm going to let him talk.
Yeah, because
Yes,
with insulin, both my parents have diabetes, and with the insulin, it's the same thing. You get the needle and you have to, like Jason was mentioning, pricking it. It's just kind of, I feel so bad, but they have to do that. They also have a pen, I believe. So what's the future, I guess, because we are coming on 100 years, the whole century after the discovery.
So I think the monitoring of glucose with these sensors, it's just incredible because it can change behavior. But it also demands that the patient takes part in ownership of their care, because just having the device is not going to make a difference unless the patient is looking at the data and making decisions about the data. So how we are, we get tired sometimes with too much information if we don't understand information. So that's also a very important part of using this technology. But I would like to add that with time, we've learned that people with diabetes are very heterogeneous, both patients with type 1 and type 2 diabetes. And with time, we have learned that there's new medications that can actually help patients come off insulin. So we're now in a world where we are treating patients with type 2 diabetes to try to come off of insulin with other medications that help you reduce weight, decrease the chances of having low blood sugars. So the technology is becoming available, but I think there's also an important factor is in individualizing in who those patients are that will benefit from certain different types of therapies, certain different types of technologies. And that's what we're learning, because the technology is advancing so quickly, the new medications are coming so quickly, and we're trying to understand how to best treat each patient based on their individual characteristics.
So with that, the wire involved, solution, you said connected to a smartphone, you're kind of like leveraging the Internet of Things model, it sounds like, and everything, and basically move kind of the computing out to the edge, in this case being the patient, which would then relay all that information back to, to a healthcare provider for constant. And I'm completely on board with that. Like when you said constant monitoring, as opposed to, twice a day pricking.
Well, we're now going through the digital revolution. And everything we do is being converted from analog, where we measure it with a ruler or with our hands, to digital, where you get an exact number. And that's affecting diabetes as well. So many of the measurements that we make can now be digitalized, put into specific numbers, and then using different computing techniques, such as artificial intelligence, you can derive conclusions from the information, because we never had this kind of information before. And both Francisco and I are on the advisory board for AI Health, which I think offers an exciting approach to diabetes in Guam. And what AI Health is going to do is make many measurements of many different factors in people at the same time. Yes, glucose, but many other factors, other chemicals that are in the blood, other physiology features such as cardiovascular, temperature, also behavior, and what's going on in the environment. And when you put together all this type of information, let's say genetic information and lab information and physiology and behavior and environment, you have a very rich pattern. It's all digital, and you can put it together using artificial intelligence. That's what AI stands for. In AI Health, they're using artificial intelligence. When you put it together, you can get a very specific pattern of each individual patient. So the days of a doctor saying, well, you look sort of big or small, or you don't look quite right, whatever it is, those will be replaced by very specific numbers. And when we have those numbers, we can do the calculations, come up with precise treatments. And that approach, which AI Health is using, is called precision medicine.
Now, I have a question, and maybe Dr. Pascal, you can address this when it comes to AI, because we've done a fair amount of artificial intelligence work here at KUM, and I guess I'm concerned with seeing, does it even bear any relevance on the fact that when the data sets are compiled, right, and you have the stratification of different age groups and people of different ethnicities and everything, when it comes to treating diabetic patients locally, is the data, like, does it translate like across different racial groups and different demographics like that? Because everybody always talks about like AI is the future and it's wonderful, but then you face the inevitable conversation of, is there like an ethical AI, and if you sample a certain amount of people, does it translate to people from all over the world? I mean, is that even a concern?
I think there's several concerns, and this is so new that we're just learning about it. So creating those, discussing this, having these conversations about equity, making sure that there's no bias in those algorithms that are telling us how to treat patients. So finding the ways so that we have unbiased algorithms that identify the patients at the highest risk with the right medication with the appropriate treatment. I think that's where we should go, and demonstrate that maybe the technology can help us actually overcome sometimes those biases. And sometimes physicians may not prescribe certain medications to patients because they may believe that they will not take them, or they may not prescribe technology to some patients because they may think that they may stop using it or not be able to afford it. So there's several issues around how we practice medicine that hopefully technology can help us. But we don't know about all the potential biases that may be there, and we have to be alert and take a good look on all those potential issues as we move forward. We're just at the beginning, I think. The use of AI for risk stratification is very helpful. It's better than the older models that we used to have. The use of AI now to guide insulin delivery is just incredible, and how we are using the data from the patient, and now an algorithm is deciding how much insulin the patient can get based on those glucose values. It's just amazing, because the technology is really reaching much higher levels of control that we saw before in patients, specifically with type 1 diabetes. But I think there's also an interest in moving that for those patients with type 2 diabetes that need insulin. And there's a lot of studies going on also with the use of technology for type 2 diabetes as well.
Absolutely. Yeah. Thank you, doctor. That's a perfect answer.
At AI Health, we're going to be studying people from Guam, and we're going to learn what their patterns are, their physiology, their behavior. So to the extent that we want to have specific local treatments, we'll be able to, because we're looking at a data set of people from Guam. And it's very possible that the best treatments for Guam are not the same as the best treatments somewhere else. But this big study we're going to launch is focused on people from Guam. And so we're not going to assume that different results are the same. We're going to see what they actually are, and then we can base our treatments on what we see.
Outstanding.
Tomorrow, both of you are supposed to be coming back to talk about, or to participate in the virtual town hall about the AI validation study. But I kind of am just curious, how was Guam selected?
Well, the company AI Health selected Guam. I think one thing they liked about it was they felt that the population was a certain size that it would be possible to study a pretty high percentage of the patients. If there were millions and millions of patients and you look at hundreds of patients, you might feel you're not looking at a high enough percentage. But I think one factor was that my understanding is the population of Guam is several 100,000, which is a good number for a study. And second, fact is, there, to my knowledge, there has been very little artificial intelligence research done in Guam.
Yep.
So this is really an opportunity to do something really new and help a group of people, we hope, that haven't had this opportunity. And then the third factor, my understanding is that there's interest in Guam in becoming more technologically oriented. For example, I live on the edge of Silicon Valley. They don't need another study, they'll take it. But I think that a high-tech study in Guam might be more appreciated even than a high-tech study where I live.
And I would even say, gentlemen, would you agree that, now it's, as Sabrina said, it's been a century since the discovery of insulin and everything like that. Moving technology and techniques to more digital platforms and basing them on AI and everything like that, and including these large data sets, it's actually only going to ramp up the pace and the tempo of medical research. So it's not going to take another 100 years to make huge progress. We're really going to get to very significant points in the treatment of diabetes really, really quickly, I would hope.
Right. The world is changing rapidly. I have an anecdote that I think is sort of unusual. I had a patient who developed type 1 diabetes in 1930, and she was pretty young then. And at that time, insulin had just been purified. It was as experimental then as many drugs now that we're not sure about if we want to take a chance with them. She went to Boston from the west coast of the US and saw Dr. Joslin, who later started the well-known Joslin Diabetes Clinic at Harvard. He put her on what was an experimental drug called insulin. It saved her life, and she came back and lived her life in California, and she lived into her 90s.
Oh, wow.
And later endowed the Diabetes Research Institute, where I work at Mills Peninsula Medical Center in San Mateo, California. So I visited Joslin and gave a talk there one time. They said, to their knowledge, I'm the only doctor that has ever shared a patient with Joslin with whom it's named. Anybody else is probably not alive at this point. But back then, people couldn't test themselves very well. And now we've got the continuous glucose monitors. We have insulin pumps that deliver insulin. We have systems called automated insulin delivery systems, in which the glucose level is checked automatically and the dose of insulin is calculated automatically. Plus, there's many other treatments involving hardware and software. By the way, when she developed diabetes, the word software, of course, didn't exist in 1930.
You guys still got me at the size of the wire, the size of a hair attached to a ball. I'm still trying to understand.
Well, I'll tell you
that.
something else too. Right now, it's used to measure glucose, but we've done some work that it looks like now it'll be able to measure something else as well, that same wire, called ketones. And although type 2 is the more common type of diabetes in Guam, type 1 is the less common. There are people with type 1, and they're at risk of a very serious, everyone with type 1, serious life-threatening complication called ketoacidosis. Mm-hmm. And if a person knows their ketone levels, then they know that it's time to get medical help. And there's even a situation, I think Francisco would be able to comment on, where there's a drug that's used for people with type 2 diabetes. And occasionally, now we're talking about Guam, it's a widely used class of drugs. And occasionally people with this class of drugs can develop ketoacidosis. Francisco, what do you think about the possibility or the risk of someone with type 2 developing ketoacidosis?
Right. And DKA, which is the kind of the short name for it, standing for diabetic ketoacidosis, we call it DKA, can occur in patients with type 2, particularly in those patients that are very sick. But more recently, we've learned that a class of medications that it's now very commonly used because it has shown tremendous effects in reduction of hospitalizations for heart failure. They're called as Glt-2 inhibitors. Now they're really amazing medications for patients with severe heart failure, and we're using it more commonly. But we are realizing that some patients that take these medications can develop higher ketone levels in their blood, particularly when they're not eating. If you think about a ketogenic diet, for example, a patient that is not eating carbs or a patient that is not eating at all, they start developing this ketone. So if a patient with diabetes that's taking these medications has anything extra, like an acute illness, or is not eating well, it starts having this increased risk of elevated ketones. And as David is referring, I think that's one of the new advances in technology is the ability to measure those ketones, and the technology is coming. So I think that's something that is going to be incredible in the future, is there's this ability to prevent those events, such as we're preventing very low sugars in patients with type 1 diabetes with alarms. So I think that the technology is incredible in the sense that we're measuring these biomarkers in real time, and at the same, we're integrating that with digital technology, with smartphones that provide alarms for patients to make decisions for those risks.
Fascinating.
A few years ago, every diabetes device, like a blood glucose monitor, is what we would call a brick. Just sat there, didn't communicate with anybody. And if you wanted the information, you had to read what was on there, copy it down on a piece of paper. So we would receive log books from people, and sometimes they would write down all their blood glucose levels and we could see how it was running. But sometimes we'd see a book that was very clean, no blood spots. The ink was exactly the same every single day. The handwriting was the same every single day. As I said, it was a very clean book. And when we saw that, sometimes we'd suspect that they hadn't really checked themselves in real time. They never had bloody fingers, but they just wrote it down on their way to the doctor's office. And that doesn't help anybody. But now all the devices we use communicate, as you said, Jason, this is the Internet of Things. They communicate with each other, they communicate with the doctor. So the person doesn't have to go to the trouble of writing them down. We can receive the information digitally and then we can act on it. And in some cases, the information can be programmed. This is sensor information, can be programmed to an effector, such as an insulin pump, to determine a dose of insulin. So the person isn't even taking any action, and their insulin pump will know how much insulin to give them based on their glucose level.
So the communication is bidirectional in that sense. And
yeah, it's called an automated insulin delivery system.
And forgive me for asking, but I only know because, like, you know, I can really geek out about this stuff. Like, and again, when my dad was, you know, and my dad had renal failure, and then he was ultimately on dialysis for a number of years. And but I remember this, I believe they said Google holds a patent on perhaps like a contact lens that might be able to do like the same thing and constant glucose monitoring, and that, like, I don't think it was a connected device like the kind you're talking about, but I've heard something like that.
Well, Google actually hired me to be their only non-Google employee to be an advisor on that project. So if you want to measure,
done. Very good, very nice.
Yeah, if you want to measure your glucose, it's not easy because the concentration of glucose in tears is only about 1/100th in blood. So a blood glucose monitor isn't going to be useful. So we helped Google develop an assay, a method to measure tear glucose. They worked on the contact lens to do the measurement, but unfortunately, they weren't able to make it work, and we were sad to hear they discontinued the project. So at this time, they're not working on it. But I read that scientists in Korea and some other places are still trying to keep that kind of method going. I hope they're successful.
Well, Dr. Klonoff, Dr. Pascal, thank you so much for joining us on the link. I know we're going to be hearing more from you tomorrow as we continue our discussion about diabetes and about AI health validation study. Was there any final comments you wanted to make?
Well, I just want to say one more thing, that Dr. Pascal isn't going to tell you this, so I will. He's running an amazing center in Emory that uses technology in the hospital. Everything we've talked about is outpatients. But if you want to know what technology is doing for hospital patients, there's nobody better you can ask than Dr. Pascal.
That's very kind, David. And it's always a pleasure to share with you. You know, when you were asking about the glucose in the eye, and I think that's a David Klonoff kind of question. So I wouldn't know about that. But yeah, so I think just to add on that part of the technology is the ability to monitor remotely those glucose levels for patients. Those patients, for example, in the ICU, we're monitoring them outside of the room, and that data can go to the cloud and we can get reports. So it's moving quickly, and now we're thinking about population health management, where we can have dashboards of patients that are uncontrolled. How do we see them? How do we identify those at the highest risk? So that's where we're going, and I think it's really promising.
Yeah, telemetry before was only supposed to be like in the medical facility, but now you can do it basically anywhere the patient is, right?
Exactly.
And with you're talking about the remote monitoring nowadays, right? With the COVID-19 pandemic, that must be, I guess, helpful.
Absolutely. We've been conducting some studies. We actually implemented that in practice to care for patients in the critical care unit, where they were not receiving the treatment that they should have been receiving in many settings because of the fear of COVID. We were using more insulin injections as opposed to the standard of care, which is IV insulin with measurements every hour of glucose. So to adjust that insulin dose in the ICU, we typically use algorithms, but the nurse still has to adjust that, and they were checking every hour. So we decided to implement the technology in the ICU, And that helped nurses to see the glucose levels outside of the room without going in every hour to do the finger stick. So that helped reduce the burden and improve the glycemic control. And we're still using it. We have a patient right now using the technology in the ICU.
Well,
That's
thank you.
absolutely tremendous.
Thank you again, Dr. Klonoff, Dr. Pascual. We will be seeing you again tomorrow, again for the virtual town hall meeting on the validation study. For our viewers, our listeners, please post your questions in the comments below right now if you want, or tomorrow. Give us a call live during the show. The number will be 671-635-5804. Again, joining the panel tomorrow will be Dr. David Klonoff, Dr. Pascual. We'll have Dr. Erica Alford, who you heard from earlier this week, Dr. Juan Espinosa, as well as Calvo Select Care, Frank Campillo, and Dr. Dolores Lee. Stay tuned. We'll have more on the link after the break.
A Healthier You, Making Diabetes History on Guam.
Presented in partnership with Calvo Select Care and Paradise Fitness Center.